it right now, and you probably see this that is recording. And if you don't like to be on this video, so please turn your video off. But if you're okay with it, and so I just would like to ask you to turn it on, because when you ask questions, it will be nice to see your face and to make it more human-like conversation. Also, I would like to ask you to turn off your voice, because you probably can make some noise and distract everyone. So please keep you muted. And if you have questions, you can ask them during this presentation. But also, we will have some time after this presentation. So just keep your notes about some questions or some misunderstandings, and we will return to this at the end of this conference. And yeah, after this meeting, we will send you some short survey. So please make sure that you complete it. It's super important for us, because we would like to make it more better better on our next meetings. So we read it every time, and it's super important for me. And so I would like to introduce you Valentina. Valentina, our medical student at Pavlov University, and today she will present our articles about COVID. So Valentina, your turn.
Thank you. I'm glad to welcome you on our online journal club meeting, and thank you for your interest. So the topic of our discussion is an article of Chinese researchers, and the name is A Trial of Lopinavir-Ritonavir in Adults Hospitalized with Severe COVID-19. This article was published in the New England Journal of Medicine, and we have chosen this topic because the COVID-19 theme is a very actual question, and no one, I think everyone knows about this problem. So let's talk about statistics. Everyone knows that novel coronavirus, designed as SARS-CoV-2, has caused an international outbreak of respiratory illness all over the world. And it infects 213 countries, and to date confirmed cases more than 2 million, and deaths more than 160,000. So new cases for today is plus 92,000, and new deaths more than 5,000. That's around the world. And what's happening in Russia? As you can see, today we have 502,000 cases in our country, and about deaths, it's very small number, only 456. And the death rate in Russia is now 7%. And the leader of this infection disease is Moscow. They are registered more than 29,000 cases. So SARS-CoV-2, it's huge international, it's a big problem. We don't have any therapeutics, and we don't know any effective therapeutics, and we don't know much about this virus. However, many researches are taken in different countries, but they are not effective. The problem is that normally the process of development is very costly and timely. And now we don't have so much time. because of the emergency of situation. That's why we try to find the effective treatment among those medications which we have. For example, antiviral medicines for influenza, hepatitis B, C, and HIV infection. However, we need something for treatment, and today the top of used medicines include several groups, that antimalarial treatments, antiviral treatments, and immunosuppressions. So let's talk about the Lopinavir-Ritonavir. This medicine is known as a treatment of human HIV virus infection. So the Lopinavir is an aspartate protease inhibitor, and the ritonavir is used just to increase the plasma half-life of Lopinavir through the inhibition of cytochrome P450. The aim of this study was to examine the efficacy and safety of oral Lopinavir-Ritonavir in treatment of the hospitalized adult patients with severe respiratory illness. And let's talk about the study design. So it was a randomized, controlled, and open-label parallel group clinical trial. I would like to recall that open-label means that everybody knew what was used. So patients and doctors knew which medicine they give. So the trial took place in Wuhan in China, and it was started at the 18th January and finished on the 3rd of February. So participants, the total number was 199. And what about inclusion criteria? The age was more than 18. All patients should have positive test on RT-PCR. And their saturation should be less than 94%, and the oxygen index is less than 300 millimeters mercury. And very important exclusion criterion. Any situation that makes the program cannot proceed safely, an allergy or hypersensitivity to the treatment, Lopinavir or Ritonavir, severe liver disease, and which causes the increase of ALT and AST more than 5 times upper the limit of normal. The use of medications that are contradicted with antiviral treatment, Lopinavir and Ritonavir, and cannot be replaced or stopped during this study period, pregnancy or breastfeeding, and known HIV infection. It's very important because it was used to prevent resistance development to Lopinavir-Ritonavir if used without combination with other anti-HIV drugs. Also, patient likely to be transferred to a non-participating hospital within 72 hours, or just it was a decision of physician. So, study medications. The treatment lasted for 14th day, and all patients were randomized into 2 groups. The first group is standard care group on the left. These patients should take supplemental oxygen therapy, non-invasive or invasive ventilation, antibiotics, vasopressor support, renal replacement therapy, or ACMO if it was necessary. And another group, Lopinavir and Ritonavir group, our experimental group. So these patients took orally 400 milligrams of Lopinavir and 100 milligram Ritonavir twice a day. And they could...
Excuse me, I have one question.
Yes,
why they choose to provide this combination? Is anyone known why they do this combination of Lopinavir and Ritonavir? why not only Lopinavir or why not only Ritonavir? What is the idea behind of this? Is anyone have any ideas?
Maybe I can say something. My name is Anastasia Холодная. I'm assistant professor at the Department of Infectious Diseases. It's a standard combination. It's known as trade name as Caletra, and ritonavir is a substance which increase the severity of lopinavir. So it's a usual combination. It's one drug in common use. That's why.
Yeah. So as I know, this is because Lopinavir have a lower bioavailability because of this catabolism features. Because yeah, so it just makes sense from pharmacological reason.
Yeah, pharmacokinetics, yes.
Yeah. Okay.
And please take a note that both patients in both groups could receive glucocorticoid therapy. For example, in standard care group, there were 35 patients, and on another group, Lopinavir-Ritonavir, only 32 patients, but the number is pretty similar. So the study flow, as I have already told, all patients were randomized in 2 groups. So the Ritonavir and Lopinavir group and standard care group. All patients who were randomized, they were named an intention to treat population. However, in the Lopinavir-Ritonavir group, during the study, died 3 patients, but they died within 24 hours after the admission, and they didn't receive Lopinavir and Ritonavir treatment. Then the researchers analyzed, and they decided to create a modified intention to treat population. So it's a group of those patients, but without 3 patients who died within 24 hours. Also, there were 2 patients among this group who didn't receive Lopinavir-Ritonavir treatment. And it was because of a decision of physician, but we don't know the reason why it was made. And in another group, in standard care group, all patients were included in the modified intention to treat population. But on the 10th day, 1 patient finally started receiving the Lopinavir-Ritonavir treatment, and we also don't know why. The median age of this population was around 58 years, and mostly they were men. Let's talk about the methods which were used in this treatment. So the main was the 7-category scale. It was used daily. So nurses used diary cards, and they captured all data on this 7-category scale, which includes 7 points. The first point is discharged to normal function, 2, discharged but unable to resume normal function, 3, hospitalized and not requiring any supplemental oxygen, 4, hospitalized and requiring supplemental oxygen, 5, requiring a high flow oxygenation therapy or non-invasive mechanical ventilation, 6, using invasive mechanical ventilation, and 7, death. So this scale was used for analyzing the time to clinical improvement, and it was the primary outcome for this trial. And the time to clinical improvement, it is time from randomization to an improvement of 2 points on this 7-category scale from the status at randomization. Moreover, this scale was used for analyzing the additional outcome, and it was the clinical deterioration. And it was a 1-category increase on a 7 therapy scale. And also this scale was used for secondary outcomes such as clinical status, duration of mechanical ventilation, duration of hospitalization in survivors, and we'll talk about it later. So on this slide, you can see a picture. It is a graph, and we can see here the time to clinical improvement in intention to treat population. And I recall that intention to treat population, that means all randomized patients. This is a Cox proportional risk model, this hazard ratio was estimated by this model, and literally this model is used to look over the time which proportion of people remains at risk and which have any improvements, and it compares over the time. So on the horizontal area, you can see the days of this trial from the 1st to the 98th. And the vertical area is a cumulative improvement rate. And here is patients who had an improvement on 2 points on the 7 category scale. So as you can see, these two lines are pretty similar. A proportion of clinical improvement, they increased both on the 16th day. Here you can see. So approximately 50% of patients improved their condition on the 16th day. As I have already told, this 7 category scale was used also for analyzing the clinical status. Here you can see the results of the first day, here on the 7th day and on the 14th day. So this was analyzed only 3 times. And I think that the results are rather similar. Look at this. On the first day, in group of ritonavir and lopinavir, there you can see 11 persons, sorry. And in standard care group, 17 persons, and they had both 0.3. 0.4 had 72 patients in ritonavir-lopinavir group, and 67 had were patients in the standard care group. So rather similar. And the same picture you can see on the 7th day, but the little difference was on the 14th day. So there were only 8 patients with the 0.3 and in the Lopinavir-Ritonavir group, at 24 patients in standard care group. And 0.2 got only 43 patients in Lopinavir-Ritonavir group and 28 in standard care group. I think that this population was rather homogeneous, but to the 14th day, group of Lopinavir-Ritonavir had a bit better results. Yes, 0.2 and 0.3, that means that the condition of patients is rather stable. But anyway, the hospitalization, it is more serious, needs more serious medical observation and treatment. Another scale that was used on the first day, it is National Early Warning Score. Actually, it includes such parameters like respiration rate, oxygen saturation, systolic blood pressure, temperature, heart rate, and all these parameters are assessed on every patient that comes to a hospital. And please take a note that there is 3 grades, so low, medium, and high. And medium includes 5 and 6 points. And if we take our look here on the top, this I recall this analysis was made on the first day. So on the Lopinavir-Ritonavir group 5, it was 0.5, and in standard care group also was the 0.5. So in both group, patients were medium clinical risk. The next test is virus testing. It was used oropharyngeal swab samples, and this test was provided on the first day before the treatment, on the 5th, 10th, 14th, 21st day, and 28th. So the measurement was using the RT-PCR test, and it was in the proportions with viral RNA detection over the time. And primary outcome. As you can see, the clinical improvement in intention to treat population was the same, 16 days. In Lopinavir group and standard care group. But in modified intention to treat population, so it is the same population, but without these 3 patients who died within 24 hours within taking medicine. It has a little difference, so clinical improvement in Lopinavir-Ritonavir group had a little bit better, so 15 days. And the secondary outcomes. So as you can see, the clinical improvement also here noticed the same. The 28 mortality also very similar, because in Ritonavir Lopinavir group 19 and in standard care group 25. Also, these patients, they were divided into 2 groups with early and late onset of symptoms. It was made to eliminate the factor of disease development duration, which characterize the disease. So in the Ritonavir Lopinavir group, there were 8 patients, and in standard care group, there were 13 patients with earlier onset of symptoms, and with later in Ritonavir group 11, and in standard care group 12. And then we to look on the clinical improvement. So it's also rather similar, these numbers, and if we take a look on the duration of invasive mechanical ventilation, also the same, 4 and 5. However, maybe here takes a role the statistical rules, and here the confidence interval includes 0, and there is a question: can we rely on these results? So here the results of 7 category scale on the 7th and 14th day, which we have already discussed. Then the virology. So the red line, it is Lopinavir and Ritonavir group, and the blue line, it is a control group, standard care. Here we can see that not all patients could be analyzed for RNA viral amount. So here only 130 patients were analyzed, and we know anything about other patients. And it also causes some difficulties with analyzing their results. Anyway, you can see that all these lines are similar, so I can make a conclusion that there was no any influence on the viral loads of the antiviral therapy.
Valentina, can you share with us your thoughts about why they failed to show virological data for every participant who was involved in this study? Why only 130 person had this data and the other not?
I think it can be related with the difficulties of this procedure. So there are several trials that say that if you take the swabs from the nasal case, then you will have a higher viral load than if you take these swabs from the throat. And also these researchers told that it was impossible to take the samples from the deeper parts of the respiratory system. That's maybe a reason for such results.
Yeah.
Yeah, I have one idea about it. Today we know that at the long term of the disease, such as not the first days, but maybe after 1 week, when we check, we frequently can find virus in the lower part of respiratory tract, not in the nasal cavity or not on the throat, but in lower parts. So if we check for throat swabs, for example, it's not surprising that we cannot find it, for example, at the day 10. It depends on the part of the respiratory tract, which sample material we take.
Thank you.
Right.
So that was the part about the efficacy, and we start the part about the safety. Also every day the nurses use special cards for analyzing the safety and different adverse events. And you can see that both groups had some adverse events, but for example, gastrointestinal adverse events were more common in the Lopinavir and Ritonavir group. The laboratory abnormalities were pretty similar also, but serious adverse events had more patients in the standard care groups. The serious gastrointestinal adverse event had only patients in the Lopinavir and Ritonavir group. And respiratory failure and different abnormalities like acute kidney injury or secondary infection were also more common for the standard care group. However, the researchers think that all deaths were unrelated to the intervention therapy. Here you can see this scale. The adverse events were analyzed with the National Cancer Institute Common Terminology criteria for adverse events. So note please that the grade 3 is severe or medically significant but not immediately life-threatening. And grade 4 is life-threatening consequences. And if we take a look on our population, we can see that there were many patients with grade 3 or 4. So in the group of Lopinavir and Ritonavir, there were 20%, and in the group standard care group, there was 11% with any adverse events.
Sorry, may I ask our expert Anastasia today, what about lymphopenia? Is it a very common side effect which well known for Ritonavir?
Yes, it's common for this medicine, but also we know that in patients with COVID-19, we also see lymphopenia, so it may be worse if we combine these effects.
Sorry, it's gone.
There was a question? Okay.
No, please go on.
So the last part of this scale. So here you can see the serious adverse event, and 17% was in Lopinavir group, and 31% in standard care group, so rather more. And let's make a conclusion. So were patients randomized? Yes, they were randomized, and this randomization wasn't concealed because of a type and specific of this clinical trial. It was open label. So everyone knows, every patient knew which medicine he took. Were patients analyzed in groups to which they were randomized? Yes, I think they were analyzed. But were these methods optimal? For example, oropharyngeal swab samples. It is rather contradictional. Maybe it was important to take everyday samples, and in this trial it was taken intermittently, so only in the 1st, 5th, 10th, 14th, 21st, and 28th day. Maybe took part in these results place of swabs. So there was taken swab from the throat, and it can have a lower viral loads than in nasopharyngeal samples. Yes, as it was said already, they couldn't take samples of lower respiratory tract.
Excuse me, can you return to the previous slide? And I would like to probably open more discussion about the methods they used and what is the, not about methods for samples, but the method they used for assessing primary outcome. So they used actually a kind of subjective clinical option, clinical scale. And what I just curious, what do you think? Usually in research, we are trying to view as much objective as we can, and we use objective scales. For example, in this study, we probably think that finding viral load suppression can be very like it should be primary outcome, but we see that it's also have limitation for using, and probably that's why researchers choose this use clinical scale as a primary outcome. And my question for you, do you think is it appropriate outcome? And if not, what should be better option. So, or there is no problem to use this clinical scale and it's pretty objective. So I think it's not really a right answer here, but I just think that it's can be a great way to, great question for discussion. So Valentina, what do you think about this? About the methods they used for primary outcome measure?
Yes, I also agree that these everyday 7 category cards and the scale of news, they can be contradictional and not very objective. Anyway, here can take role humans factor. So any small mistakes maybe, and in my opinion, more reliable results are laboratory results. And I think that the efficacy of antiviral therapy must be proven by the laboratory methods like RCT method or anything like it.
And maybe I'm mistaken, and Anastasia can say more rightly, but I think that it depends also with that we don't know how long virus still remains in the organism after clinical improvement. And so maybe if we will think about that, there were and some limit of places in hospitals, so maybe some of these patients, they were returned home, and it was difficult to, I don't know how to say. It was difficult to make their tests for searching their viral load in more long time. So
I think they do this. So they only do this assessment while the person was hospitalized, as I understand.
Yeah. That's what I mean. So because maybe they just couldn't do these tests more later, and so.
Okay, I guess that if we talk about Chinese studies and their situation, I know that it was their approach to test not only at hospital, but to do the final tests when the patients were at home. And as they said, the patients usually received these tests at home during the next days after hospitalization, after they recovered. So I guess for this study, they use the same approach.
Yeah, but the problem that when you look on the virological data, about like 60% have no virological data, so they not so they have undetectable viral load. And the point that how you measure the efficacy of your treatment, if it's based on virological data, if it's already like good in the baseline.
Yeah, of course. I think that virological data it's not enough, and of course it cannot be the first line for this assessment. And as for me, I guess that it may be a combination of CT scan picture and maybe some inflammation markers. First of all, because in the severe course of the disease, we see high levels of ferritin, of C-reactive protein, etc., and they predictors of the severe course. So maybe we can, based on these markers too, additionally to the clinical picture.
So your suggestion will be to add to this primary outcome, to clinical scale, to add more objective measurements, is computer tomography results and inflammation markers.
Markers of inflammation, yes, I think that is the first line, maybe even more useful than CT picture, because we still do not know enough about this picture in these patients, and it's not always correlate with the severity of the disease course in these patients. Sometimes we can see severe damage on the CT, but there is no so obvious severe clinical picture.
Yeah, my point that actually that I'm kind of big fan of objective measurements, and I really like your suggestion. I actually think that in this paper that they use subjective one, and it's kind of based on not on like patient answer, but based on clinician examination, and actually clinician make this assessment, and they look on the how on clinical picture of their patient, and probably I assume that the clinician assess this during their participation of the study, so we can make the assumption that the assessor was the same and the clinician have the same criteria for choosing on 7 category grade on 7 category scale. So I think it's pretty valid method for observation any effect of treatment. So, and from my point of view, what we try to treat here, we know that right now there are no treatment, and we don't really know what is the mechanism of the disease, and like is the key mechanism for the disease. And I totally agree with CT and inflammatory markers is the good measurement for looking on the disease development and progression or recovery. But I still think that it's important what how patient feel, and did the participant need oxygen or not. And I think this scale which they use, it's pretty clear classify this patient and to put like 7 category of different severity of illness. And the treatment is not probably doing something with it's we don't know what is the mechanism of this action in COVID, and we don't really know how it's how long it takes for make some changes in your lungs, or how long it takes for making some changes in your inflammatory markers. But we know, like clinically, we see this effect, and so that's why I think I totally agree with to have some objectives in your pocket. It's great, but I really like the scale which they use, because I think this is in the condition which we have right now, the condition of uncertainty. We don't really know about what we would like to treat and what was the other target. So that's why I think they don't really use these like objective measurements.
Maybe, but I have some idea about it. Sure, we first of all treat our patients, and it's the most important part, how they feel after our treatment. But if we receive some baseline measurements, we also can further divided them into some subgroups. So maybe in our group treated by Lopinavir-Ritonavir was some patients who at baseline have high levels of systemic inflammation markers and patients with lower levels. And it means that patients who at baseline have lower levels are more likely to have better results
Yeah, totally.
after treatment. So if we haven't this data, our results are not so objective.
Yeah. Great point.
And about some limitations in this study, which I also see, is that the baseline time point, it was chosen like the low saturation, lower than 94%, and the researchers didn't compare these patients with the early treatment approach. So I mean that maybe we should treat with Lopinavir-Ritonavir not only if there is respiratory deficiency in patient, but maybe we should start it early, and in this case we will see some better results. Maybe it should be another group. And one more little notice, if I understood right, about the 30% in each group received glucocorticoids. And today we know that that medicine not recommended for these patients because it was shown that glucocorticoids increase viremia in these patients and can lead to worse outcomes.
Yeah.
So it's maybe it is because the study was conducted at the early period of epidemic, and there were no this data, and it is one of the common approaches to treatment of these patients. That's why these patients maybe received glucocorticoids, but today we know that we shouldn't give glucocorticoid to patients with COVID-19, and it's one more reason why we should add some corrections into design of this kind of study.
Yeah, and actually I think that they shouldn't give these corticosteroids not just because we know that it's not beneficial for our patient with COVID, but also because it just adds some mess in your intervention, and how you can make a conclusion about how effective your intervention if you mix everything with your intervention. So,
there were equal parts of these patients in the group, if I
yeah.
But oh no, of course.
Yeah, I think they like it that it was kind of stratification, and probably it's like so between groups there is no difference in the proportion of those two.
Yeah.
So kind of like that. Okay, what next, Valentina? What do you notice?
So yes, I have also noted about this problem with glucocorticoids, and also I noted that we don't have any information about the antibiotics, vasopressors, and such medicines. So maybe it was useful to create another confounder and analyze it. So another problem is maybe we can use higher and longer this Lopinavir and Ritonavir treatment, and maybe it's useful to increase their dose regimes in order to improve outcomes. But on the other hand, these trials shown that approximately 14% of Lopinavir-Ritonavir recipients were unable to complete this full 14-day study course of administration due to the adverse events. So I think the answer on this question is no.
Anastasia, what do you think about this? I'm just curious, like, what if we can, I don't know, to pursue the goal of being effective, just add dose and.
I think that if we increase dose, we will receive even more adverse events related to this drug, because they are really common, and the complete course, who decided that 13 days is a complete course or not, for example, 10 days. I think that it was some just in case decision, because we have no previous data of using this medicine for this kind of viruses. So, of course, it's a typical approach to increase dose or to prolong treatment, but we cannot be sure in this situation that it will have some benefits opposite to adverse events, to intensification of these adverse events.
So, and we are trying to be no harm, don't harm.
We still do not see significant positive effects. So.
Okay, so probably we just see this kind of negative results trial.
So let's talk about conclusion of this trial. I think that this trial shown that Lopinavir and Ritonavir treatment had no efficacy in a randomized open label study. They also, this treatment also didn't have any significant benefits in mortality or reduction in viral load, which can be associated with the procedure of tests. It also wasn't associated with mortality in seriously ill patients, and maybe this treatment only reduced serious complications or requiring non or invasive mechanical ventilation. So about limitations, I think it was the type of the trial, so open label. The lack of blinding could reduce the study objectivity, and important that we don't know much about the used medications, and this usage of glucocorticoids also could make the clinical history worse. So will the results of this trial help me in caring for my patients? I think yes. Anyway, it's important to know about this trial, its results, because this medicine, Lopinavir and Ritonavir, is used in Russia for seriously ill patients with COVID-19. So anyway, we should know about this medicine and search more information about the most recent and new trials to examine what's what they have differ from this trial and analyze. Thank you. I think that is all for now.
Yeah, so this is time for questions. Well, if you was shy. I don't want to interrupt Valentina as I did before. So this is the time for your questions. Please, we would like to any kind of question related to the articles or suggestions or any other ideas, maybe ideas for further studies, or what advice you can give the researchers. For example, if you have chance to talk with researchers who write this article, what you can advise to them. And I don't know, maybe you don't agree with any of us. We discussed a little bit about the measurements, about methodology they used, and please feel free. We are kind of very friendly here, friendly atmosphere, and we would like to share our ideas. So,
Valentina, I have one question because I know that the researchers start to study the effect of Lopinavir-Ritonavir because it was shown in previous viruses such as SARS and MERS that it may be effective. Maybe you've checked which study designs they tried previously in these other kinds of viruses, which patients they tried to treat with it. That was the approach when they started at the severe course of the disease as in this study, or maybe they definitely started in the early stages, like at the first symptoms of the disease. So did you see studies with this medicine related to SARS and MERS disease?
Unfortunately, no, I haven't checked these old trials which were held in 2000s, in the beginning of 2000s, so I can't comment especially.
I think that it may be useful to compare the approach.
So you propose that it's important to look on what is our sample and what is severity of the illness, right?
Yep.
So,
I think so.
In previous study, it probably showed efficacy because it was less severe disease, and in this study we see that sample was kind of severe ill persons, so that's why we probably don't see any effect.
Just idea like this.
Yeah. So I think there is also kind of limitation of the thing that probably should be on the title of this paper, that the population which they study, it's kind of unique because this is not because the having disease of COVID-19 is kind of very wide term, and which include range of different stage of disease, different severity of disease. So in particular in this paper, their participants kind of more severe than other patients. So and I think that's also make the researchers kind of ambitious, because they're trying to find the effect in the cases when probably have like less hope, and so less chances to see the effect, or maybe not, because probably the more severe cases you have, the more visible effect you see. So what was or maybe it wasn't planned by the researchers, and they just include those who was in the clinics. But as you noticed before, their inclusion criteria was kind of restrictive, and they actually focus on more severe cases. So why they do this is kind of, it can be two like different reasons. They not explain it. But I think it's great point.
And I can explain why I'm so focuses on the idea of the start of antiviral treatment, because today on our patients we see that in our medicine, hydroxychloroquine, it's a clinical impression, just it's not a kind of data of a clinical study, but it's an impression that if we start it early, we receive better results. We do not see such severe disease after it.
Yeah.
And if we start in patients who are already severe, we haven't seen such big effect.
Yeah, but actually they kind of try to do this. Valentina, would you like to explain my thoughts? Do you get it or not? Do you remember that they try to look on subgroup, and they actually make subgroup of those who have disease, have this duration between the date of onset of symptom onset until a date of randomization, less than 12 days and more than 12 days. So they kind of actually try to do this like to make subgroup analysis, divided onto like groups based on their duration of illness. Here you see mortality rate depend on this, but they actually and you can find it actually on supplementary tables. They try to find some results on these subgroups, and they fail to find it. So,
and interest why they choose this point like 12 days.
Yeah, this was my question as well. I have no idea. Valentina, do you have any?
You mean why they have chosen 12 days for?
Yeah, like cutoff, like why 12?
It can be related with the severe what's COVID can problems with English. So maybe they thought that if we give medicine patients with more earlier onset of symptoms, so that means that this COVID is more severe for this patient, and it could be useful to take medicines much earlier than in those groups patients which have the onset of symptoms later, so like more than 12 days. And they wanted to see whether this point, the hardness of disease, could influence on the on the clinical improvement, except the therapy. So that's how I understood it.
Yeah, but still there are no clue why 12. Why not 20? 7? Like they don't make some explanation on this cutoff.
No.
What do you think, Anastasia? What will be a good cutoff?
You mean that?
Like if you would like to do some subgroup analysis, when we can effect of.
I guess that depends on the clinical manifestation. Because in some patients we've seen the severe course from the onset. In other, we see that they becoming worse at the day 5 to 7. days. So at least maybe day 5 or 7, because it's one time point in which we clinically usually can see the how to say, not improvement, but opposite to it.
Deterioration.
Oh, yeah, deterioration, yes. Thank you. So maybe this time point, but 12 days, for me, it's too long.
Mm-hmm. Yeah, probably.
Mm-hmm.
Thanks. Great. Is anyone have any questions, concerns, comments? Please.
I have some unclearance in this slide about the diverse effects. Can you return, please? No, next. Oh, just about serious adverse event. As I know, this group of Lopinavir-Ritonavir, they received the same standard care plus Lopinavir and Ritonavir. Yeah?
Yes, if it was necessary, they could add this standard care group, and as mostly patients were with severe illness, they had this therapy.
And so why adverse event of standard care are bigger and more serious than Lopinavir-Ritonavir if logically it they have to be like adverse events of standard care plus adverse events of Lopinavir and Ritonavir, or no? Maybe it's not a question for you, it's just unclear for me.
I think it's a good question. So standard care group and Lopinavir-Ritonavir group could be different only with this medicine, Lopinavir and Ritonavir. So in standard care group, they didn't have this medicine. So maybe if we don't see any improvements in the viral load or any efficacy or anything else, but maybe this Lopinavir and Ritonavir group could help to avoid the serious adverse events, but anyway, we don't know why and how did it work.
Thank you.
Yeah, I think that it's kind of a interesting finding, and we probably can say that exactly like Lopinavir-Ritonavir probably safer than standard care, but it wouldn't be actually well conclusion, because
Yes.
it's not really significant difference between these groups, and the point that adverse events, they can be reported in like, and it's kind of not really predictable, and why we look on adverse event, we are trying in the study, we are trying to see what is the safety of our study medication. In this case, is Lopinavir-Ritonavir, and this was the first goal. And maybe I'm wrong, but I believe that, and Valentin just said that Lopinavir and Ritonavir was used with standard care just if it was indicated. Is it correct? So
Yes.
it means that standard care for someone who don't receive Lopinavir and Ritonavir can be very different from the standard care which was in this group, Lopinavir, Ritonavir. So, and this is one of the limitation which was also mentioned by Valentina about we don't really know what is standard care. So they, of course, they put some details on the standard care, but it includes so many interventions, and we don't really know about the doses, about duration of this pharmacological treatment, and it's standard care. It's just look here very like standard, but it's not really standard. It was kind of unique for every patient. So that's why I think this is what we have, and I think that it's not really good data for making any conclusions and to thinking that Lopinavir just like save patient from adverse events. It wouldn't correct, but I think this is just show that it's just for us to remind that standard care is kind of not really standard, not and it's include a lot of caveats which can result in the adverse events. So hopefully it answers your question.
Yeah, thank you.
Point. Okay, the time is actually I look at the time and see that we actually should be done in 30 minutes, but I hope that you enjoy our discussion, and please make sure that I have your email. If I don't have it, please write me something and I will send you survey. We do this every time after our journal club, and we collect information about your impression about journal club. We would like to know, is it helpful or not? Should we repeat it or not? And what you like and what not? What should be modified? So please take just like a couple minutes and give us your feedback. Hope you enjoy it and have a good evening. So it was my pleasure. If you have any questions, please email me. That's it, probably. Valentina, do you have something to add?
Yes, I would like to thank you all for your attention, and I hope that it was interesting and useful for you.
Okay. Anastasia?
Thank you so much. Yes, it was very interesting for me discussion. And of course, the topic is highly relevant for today. So I hope that everyone have a pleasure to discuss this kind of actual study.
Possibly not very optimistic results, but
yeah, still not very optimistic as all situation. But we are optimistic, and it is important, I think.
Okay. So next journal club will be in May. So hope to see you next month. So thank you again.
Okay.
Thank you.
Thank you.
Thank you. Bye.
Bye.
Bye.